just a minute, as well as Dawn Smith. I want to welcome everyone today, no matter what time zone you're in and where you are in your day, beginning, middle, or end. But we're delighted you're spending time with us here on what is actually a second in a series of webinars related to the guidelines related to oral pre-exposure prophylaxis, or PrEP. And I know we're starting a little bit late, and we are recording this call so we can post it on a clear line and post the recording. We will be opening the line later for questions, as well as happy to take your questions as we go in the ReadyTalk chat function if you're online seeing the slides, or via email at avac@avac.org. And please feel free to send those questions in as we go. But the order for today is two presentations, one from the World Health Organization, and it will come from Rachel Bagley, who leads the HIV prevention programs at the World Health Organization headquarters in Geneva. We'll then follow that with a presentation from Dawn Smith, who probably has the longest running experience with oral PrEP, having been one of the early investigators in a PrEP clinical trial many years ago, for those of us who have memory still, and has continued leadership at the Centers for Disease Control and Prevention based in Atlanta, and has led the guideline development process, which has now been many years in the making, since first proof of efficacy, and even beginning before the efficacy was demonstrated back in 2010. As everybody on this call knows, this has been a long and challenging at times, but very exciting road over now more than 15 years, demonstrating first that PrEP was safe and effective, at least with oral TDF-FTC, and then trying to understand together as a global community how we translate those clinical trial findings into practice, and most importantly into public health impact. And in the United States, the Centers for Disease Control and Prevention, and globally the World Health Organization, are the key agencies to help implementing organizations and governments, ministries of health, AIDS control programs understand the evidence and act on it. And really grateful to Rachel and her team at WHO, and Dawn and her team at the CDC for joining this webinar to give us an update on the guidelines from both organizations, and that is the purpose of today's call. So again, I encourage you to send questions as we go at either avac@avac.org or in the chat feature at ReadyTalk. And without further ado, I will start by turning it over to Rachel Bagley, who, as I said, leads HIV prevention activities at the World Health Organization, and who's led both the original recommendation of oral PrEP for prevention, and then subsequently the guidelines development process. So Rachel, over to you.
Thank you very much, Mitch. Can I do the slide? No. Can you do the next slide? I'm just going to talk, as Mitch has asked me, on how we the processes that we in WHO went about to make the guidelines. Talking about what our products on PrEP are, and key issues that we think need to be addressed as we move PrEP forward. Next slide. So
Rachel, as we're getting, just before, I hate to interrupt you, people are having a little hard time hearing you, so if you could speak loudly and clearly, if you could, into the handset, that would be great.
Okay. So why at this moment is it so important to have a guidance on HIV prevention? Next slide. Well, as these latest figures show from the UNAIDS GAP report, which was produced towards the end of last year, we've done fantastically well on preventing new infections amongst children through prevention amongst child transmission programs. But we've done much less well, despite a really significant increase in treatment to stop the flow of new HIV infections. And so we really want to make the most of existing and new prevention tools. Next slide. So how do we make guidelines? WHO has a very formal process in which we make guidelines, and we have a guidelines review committee within WHO that scrutinizes the process that we undertake to make guidelines, which we have to follow. And our guidelines have to review all the evidence. We're a neutral agency. We're not an implementing agency. And our focus, and this is very important, is on low and middle income countries. And when we make guidelines, we use the grade process. Next slide. And the grade is a way of systematically looking at the evidence from published studies and using this to synthesize this evidence so that we can decide the strength of a recommendation. Next slide. The WHO has a whole range of different guidance to support countries when they're looking at issues like PrEP. So we have our normative guidance. This is the guidance where we follow the grade process, and this results in recommendations. And these recommendations apply, unless they're particularly specified the country, to all populations in all settings. And so once these sort of top-level recommendations are made, they are normative guidance for all countries and regions. We then have the next level of guidance, which is our implementation guidance. And again, we try and reflect all available implementation experience. And this type of guidance is suggestions. It's not as firm as the normative guidance. Although there are many common principles and elements in implementation guidance, we recognise that the guidance issues will vary across settings and across populations. And countries will adapt these to their needs. And this again, I think is very relevant to implementing PrEP, which is going to be extremely different in Europe, for example, compared with in Swaziland or in Ukraine. So we really have to acknowledge that these are suggestions to countries and shouldn't be seen as firm kind of recommendations to do things in such a way. And then we work with others in general to make tools that really support countries to take this information into practical ways. And in general, WHO doesn't do this kind of work. We work with a whole range of partners, and it may be tools for a particular country or setting, or it may be within another agency such as the USA or CDC, to really work together with them to make some practical tools that will help countries implement. And then finally, we work on monitoring and evaluation, and this is, again, very important for PrEP, to really see if we can harmonise the monitoring and evaluation of PrEP across different settings to make this both safe and as effective as possible. Next slide. Our target audience of WHO is always primarily the Ministry of Health, and that's our main partner. And so we always want to make guidelines that are supported by the Ministry of Health, and particularly we take the PrEP obviously for national HIV program managers, and they would be responsible and we work with them to adapt the recommendations to the country level. However, we also have another range of stakeholders that we would hope would find the guidelines useful. Program implementers, civil society organisations, and organisations both domestic and international who will be considering funding programs. Next slide. So the key principles that WHO has in making a recommendation is that we use a whole variety of data, experience, and information to look at our recommendations. Most the first thing we look at is all the trial results, randomized controlled trials, being at the top of the evidence chain, and then looking at the observational studies. However, this is not the only thing we look at. We look at values and preferences, and for example, in PrEP, this is something that we have done extensively over our development of guidelines, looking at the values and preferences of groups who might be potential PrEP candidates, as well as those for providers. We also look at the cost and the feasibility. And all this evidence is taken into consideration when we then make that step to making a recommendation. We acknowledge sometimes the evidence is not perfect, but we, as WHO, with the support of our guidelines group, take this into take all the evidence available and then make a judgment. And public health is at the centre. Next slide. So who makes the guidelines? At WHO, we have a guidelines development group, which is convened to make recommendations. And we have, again, a very formal process by which we invite people to pass that guidelines group. The members of that guidelines group, their names and biographies are posted on our website. They have to fill in declarations of interest so that we can make sure that these are transparent and shared amongst the guideline group and wider, so that we can ensure that people who don't have potential conflict of interest are part of this development process. And we try as much as possible to have gender and geographic balance and representative from the Ministry of Health and implementers, from people who might use the intervention, and civil society, community, and of course researchers. In all our guidelines processes, be they PrEP or other guidelines that we've worked on recently, such as key populations, we found it extremely important to have strong civil society input, as well as our usual, the usual kind of partners, the WHO, the Ministries of Health, and the researchers. Next slide. So over the past 2 or 3 years, we've really tried to consolidate our guidelines, and we have 4 streams of guideline work: treatment and care. And in 2015, this included 2 major new recommendations on immediate treatment for people with HIV and the offer of PrEP. We also have consolidated guidelines on HIV testing, and these have been updated just at the end of last year to include new recommendations on self-testing and assisted partner identification. We have key population guidelines, which encompass the recommendations both for the treatment and care and for the testing, and a whole range of other evidence-based recommendations for key populations, including best practice recommendations on social and structural issues. And then we also have strategic information guidelines. Next slide. So how do we make a recommendation in our guidelines? We look at all the evidence, and as I said previously, we look particularly at clinical trials, and with randomized controlled trials being the hardest of the evidence we look at. And then we also look at additional observational studies. We employ somebody to look at this systematically, looking at the GROW process, and if possible, we make a meta-analysis of studies where we can have where they have similar population outcomes. Next slide.
Hey, and Rachel, as we go to the next slide, I know people are still having a somewhat hard time hearing you, so if you could get even louder and closer, that would be awesome. Thanks.
Okay. I've got the phone completely at my lips, but I will try and speak louder. So our planning process is very formulaic and follows this chart here. We decide to produce the guidelines, and that's usually because we see that topic is very relevant and could benefit countries. And we scope out what issues would be potentially involved in this guideline. We then develop the guideline group, as I outlined, and with that guideline group, we make the PICO questions, the questions that we want to answer that will be the basis of our recommendations. And then we propose this to our guidelines review committee, and then they say go ahead or not. Next slide. We then gather all the evidence, we systematic review, we put this through grade, and then we have a guidelines development group meeting where we look at the evidence, we look at the systematic review evidence, we assess the values and preferences, the study that has been done, and for example with PrEP, we've commissioned particular studies with key populations networks and other groups so that we could make sure that these were really reflected in our discussions about the guidelines. We look at available costs and we look at feasibility. And it's that group then makes a proposal for the recommendation. Once that's done, we write the guidelines and then we put them out for peer review. And this is a very, very intensive process. And for example, for the PrEP guidelines, these were reviewed by more than 200 people from a wide range of different backgrounds from all regions and encompassing a large range of civil society networks and organisations. And when we've addressed the extensive peer review, we then go through a clearance process. Next slide. We then lay them out, and then we disseminate them. And this is the formal process of getting our guidelines into the kind of so that everyone knows about them. And this we did in 2015. And really, in some ways, this is the start of the process, because making a recommendation is in some ways the easy bit. How we then implement that and how we support countries is then a much larger process and involves many more partners. And that's really where we're at the moment. And of course, making recommendations is not is a process that will need continuing update and if new evidence becomes available at any point in time. Next slide. So a recommendation to be strong or conditional, and strong means that it applies to every place. Conditional will mean that it will apply to some populations and maybe not for others. And then it can be a recommendation for something or against something. Sometimes the guidelines group decides not to make a recommendation at all, and we did this initially when we made the first recommendations on PrEP in 2014, when we did the recommendations under our key populations guidelines, and we made a recommendation there for PrEP for men who have sex with men, but we didn't make a recommendation for people who inject drugs. Although there was evidence, the values and preferences of the groups who represented people who inject drugs made us outweigh the evidence that was published on showing the efficacy of PrEP in this group. And again, I think that's a very important point to make, is that although evidence is there, if these other factors outweigh that evidence, we can end up not making a recommendation. And just to not labour the point, but really to emphasise the reason for not making a specific recommendation for people who inject drugs was the fact that harm reduction, needle syringe programs, and opioid substitution therapy if implemented, have benefits for HIV prevention, which are highly effective, cost-effective, and have benefits beyond just HIV prevention, and should be prioritised before considering PrEP. Next slide. So these are just some examples of the way that we can have recommendations. The first recommendation, our PrEP recommendation, is a strong recommendation with high quality evidence, and we therefore put the word should, that the recommendation applies to all populations. The second recommendation there, which is looking at tests for rapid tests for infants, because there was little low quality evidence and much variation in opinions on this, it was a conditional recommendation, hence we use the word can. And the third recommendation, a TB recommendation, very much like the PrEP recommendation for with drug users, no recommendation was made. Next slide. So all this huge amount of work ended up with us making a strong recommendation because the evidence was of high quality to support offering PrEP as an additional prevention choice for people at substantial HIV risk as part of combination prevention approaches. And that's the basis of all our ongoing work on PrEP. Next slide. I mean, this is a slide everyone knows. We were very lucky in many ways to have such a large body of evidence to support this recommendation. Often WHO makes recommendations and we're not so fortunate to have such clear evidence to show efficacy across populations and across settings. Slide. And what's this recommendation all about? It's an enabling recommendation, so it's not population specific, and so it really allows PrEP to be considered wherever people are at substantial risk, whatever risk group or risk behaviours they have, has no age or gender issues in that recommendation. We also note it should be an additional prevention choice, and this is again something that the guidelines committee really wanted us to emphasise, that PrEP should not be seen as a standalone intervention for HIV prevention, but people should be offered it with all the other prevention interventions, so that they can make a choice to what will suit themselves. And also, we should put PrEP within a comprehensive support service. And this really much feeds onto the future work that we're doing on implementation guidance. We do not see PrEP as something that will be offered in isolation. It should be offered with counselling support, appropriate social and legal support, mental health and emotional support, and a whole range of other services supporting the population, so contraception, reproductive health services, for example. Next slide. So in 2015, this recommendation was part of our consolidation guidelines, and an updated version was made in 2016, where we made some changes, and one of those changes was something that was discussed in the previous webinar, was the time to protection. And in that interim period, we looked at additional data and modified that to suggest that this time for protection was shorter than we'd originally proposed, and we wanted to harmonise it for all populations. Next slide. Next slide. Another issue that came up after the guidelines were made was the use of PrEP during pregnancy and breastfeeding. And although at the time of the original recommendation in 2015, we had stated clearly in the guidelines that PrEP should be continued for people at substantial risk during pregnancy and breastfeeding, countries concerns that this was an issue, and it was leaving countries after with a situation that somebody starting on PrEP who became pregnant because often on the package insert on TDF-FTC, there was a contraindication for pregnancy and breastfeeding that people would stop. And this was putting people, women at potential risk, at high risk. So we had another process to extensively look at the published literature, pharmacological studies, the use of TDF-FTC for treatment, TDF for treatment in people with hepatitis, and the information from PrEP trials where women became pregnant. And we looked at all this review of this literature. Next slide. This review was carried out by Lynn Mofferton and has been published in AIDS, and again confirmed that with all available evidence, PrEP use during pregnancy and breastfeeding is considered to be safe, and women who continue to wish to take PrEP during pregnancy and breastfeeding because they remain at substantial risk should be supported to do so, because that not only has protected for them, but is also protected for their infants. Next slide. So we've done the guidelines. We've made a couple of updates, and certainly we're certain that over the next coming months there will be other things that we need to address more systematically. But what we're really working on at the moment is our implementation toolkit. Next slide. It starts, it's a whole range of modules for different audiences, and the first one is really, and I wanted to highlight this because this is something that we in WHO do a lot, is really to start that conversation with ministries about how they can start to consider PrEP, and these are the issues that come out all the time. The cost of PrEP, how do we start? We've got a huge potential population that could benefit from PrEP, but really how do we prioritise that, given that we can't, for example, in Swaziland, give PrEP to the entire female population. People feel concerned about toxicity for taking PrEP, drug resistance. Another issue that comes up in many conversations with ministries is offering PrEP, will that actually undermine other programs, particularly condom use, and will it therefore lead to more STIs? I mentioned the safety in pregnancy, and also concerns from transgender populations about will this interact with drugs used for transgender populations. We all know from the evidence from the trials that adherence has been an issue, and particularly for some populations, poor adherence, people not taking their pills, obviously means that PrEP will not be effective. So we need to also look at ways to support adherence. And then finally, we have very limited data to date on PrEP use in under 18 girls. I know, and it's great the work that Mitchell and AVAC does, that we've got great information on a large number of projects that are already going on for adolescents, both for adolescent girls and for young MSM, and we will have much more data on that, and I think we'll be able to be much firmer about what we can recommend for this group, both in safety, but also in support for adherence. Next slide. So this implementation toolkit, which will be coming your way soon, has a whole range of modules. So political leaders is the first one, really to advocacy materials to really get people who are making decisions about HIV, support the use of PrEP. Community advocates, involving communities, really get communities to understand how PrEP will benefit, what PrEP is, and what PrEP is not, who could possibly benefit for it. Make some regulations to overcome regulatory issues. A public health chapter, which is there to support countries to prioritise PrEP in in the most effective way. How to plan PrEP services, our clinical chapter which looks at the safety and efficacy of PrEP and how to deliver it, a chapter for counsellors, labs, pharmacists, a chapter for PrEP users, and then finally how to monitor PrEP. Next slide. So in the clinician's model, we look at how we can identify people who and support people who might choose PrEP, the testing issues, looking at same-day start versus delayed start, looking at the pre-screening and monitoring, and then issues for different populations. Next slide. And this is just a little snapshot of our kind of PrEP essentials and the PrEP screening. Next slide. So that is really a snapshot of how WHO makes our guidelines. It hopefully underlines what we mean by our recommendations and how this is something that we want to support across all populations. Our guidance, which is really suggestions for countries, and they will adapt according to their situation, availability of commodities and resources, and finally working with others to move these implementation guidelines into something that's really usable in countries and populations. These are the websites for the guidelines that we prepared, and we hope that we will have these launched fully at IAS in Paris, and we are planning a launch satellite on the Sunday, and we look forward to seeing as many of you as possible to be there. Thank you.
Great. Rachel, thank you so much. I know people did struggle with both quality and getting into some of the content, and I know a lot of questions are on the table, which I do want to get to. We did start a little bit late. I want to jump straight to Dawn Smith. Dawn, if you can present, and then we can get into the questions and conversations, which I know people want to get to as quickly as possible. So I did a fairly lengthy introduction early on, but as if you're just joining, that was Rachel Bagley from WHO. We're now going to turn to the Public Health Service guidelines for PrEP here in the United States, which were led by the Centers for Disease Control and Prevention, and that process was led by Dawn Smith. So Dawn, over to you.
Okay. I'm going to go through how CDC approaches developing guidelines, and in the spirit of this webinar, coming from a discussion about why WHO guidelines and CDC guidelines don't always say exactly the same thing, it's useful to kind of think about what Rachel has described in their approach to developing guidelines that apply to multiple countries, as I go through what one country, the U.S., does with its guidelines. Next slide. So one of the things that became really clear to us as we were getting ready for the first data to come in, is if this works, how can we make this implemented as quickly as possible? And it was very clear to us that guidelines were a key part of that. In the United States, it takes about 17 years for a clinical trial finding to make its way to standard of care implementation. And the development of guidelines is a big part of driving that implementation. With PrEP, we're actually doing great in terms of the timeline that's experienced for most clinical interventions, in that, it would take 6 to 13 years from publication to guidelines. It took us 6 months to the interim guidance and 2 years till the complete guidelines. So we're actually ahead of schedule, and I think we're seeing the effect of that on uptake of PrEP in the United States. Next slide. So when we think about what the guidelines process is about, we think of it in multiple stages. So there's evidence generation, which are the clinical trials and observational studies and other ways of getting the data about PrEP and how well it works. There's a process of putting all that information together in a logical way, and then deciding what the guidelines should recommend as policy around that intervention. That then gets put into practice, and at the level of the patient-provider interaction, that all results in a clinical decision. And that clinical decision is jointly determined by the evidence, the patient's clinical circumstances, and the patient's desire for one or the other treatment options. Next slide. So, clinical practice, the CDC guidelines are what are called clinical practice guidelines. They are a subset of the entire universe of guidelines. Obviously, we have guidelines that are about other things than clinical practice. They may be about policy standards or other things. But clinical practice guidelines are, according to the Institute of Medicine, which is an important body in the U.S., evidence-based statements that include recommendations that are intended to optimize patient care. CDC guidelines are intended for use by U.S. clinicians. Although we know they're widely read and used by others, their intended audience is U.S. clinicians. In the U.S. healthcare system, they are not meant to be regulations. They're not enforceable. People are not punished for doing things differently than the guidelines. But instead, they're intended to recommend best practices, the best way to achieve the desired clinical outcome. Next slide. So the first thing we had to decide when writing the guidelines was who is the primary audience for our guidelines. And in this case, we decided it was primary clinicians who are the ones who are providing health care to people without HIV infection in the U.S. system, clinicians who provide substance abuse treatment, and infectious disease and HIV treatment specialists, because even though they're seeing positive patients for the most part in the U.S., they may be in a situation to provide PrEP to the uninfected partners of their patients, or they are frequently called on as consultants for primary care or other kinds of clinicians who aren't really sure about prescribing antiretrovirals to negatives. Also, the policymakers for the organizations within which these clinicians work were primary audience. But we were well aware that there are many other interested audiences, and that includes our local and state health departments, our community-based organizations, people who might be interested in using PrEP, researchers, as well as prevention advocates. Next slide. So given that our primary audience was clinicians, we took a look at the literature about what kinds of guidelines are associated with uptake and use by clinicians. And so these are the factors that came out in the literature. They need to have a clear evidence base for the recommendations. You need to have a very precise definition of the recommended performance. Clinicians need to understand exactly what it is that you're recommending that they do. It needs to be supported with a discussion of the risks and benefits. And the feasibility and acceptance of the recommendations needs to be assessed in the target group, in this case, primary care clinicians. And lastly, the recommendations should be stated in a way that facilitate integration into their existing clinical practices. If you make recommendations that say change everything that you're doing and do it this new way, you get very slow adoption. Next slide. In terms of the time that we took to develop the guidelines, in general, some guidelines are only developed years after, but in this case, we felt it was important to develop guidance fairly quickly, mostly because even though HIV infection is a severe disease and the feasibility of PrEP seemed good, cost effectiveness was not really known, but in the United States, the drugs that are used to treat PrEP were available immediately. And at the day after the trial results came in, patients could walk in and get a prescription for PrEP. And so we felt it was very important to have guidance early on. We were concerned about the complexity and the cost of effectively delivering PrEP, but we also wanted to ensure that clinicians had guidance for how to integrate it with other prevention strategies. Next. So we have several kinds of guidance documents that CDC produces. The first is a brief statement on principles of use. These are what we used as interim guidelines, and these were short documents that were issued within a few months after each positive trial result. So for MSM, for heterosexuals, and then for IDU. In the meantime, we were working on a full guideline, a comprehensive guideline, which has wide stakeholder engagement, opportunities for public comment, gets reviewed by multiple federal agencies in the U.S. that are involved with health, and serve as the long-term basis for monitoring and evaluating the implementation of PrEP. And then lastly, we develop program implementation guidance. These are very specific for their intended user population. So this might be implementation guidance for an STD clinic that's providing PrEP versus an injection drug use treatment facility that's using PrEP. Next slide. So the interim guidance, the guidance for men who have sex with men was published in early 2011, just after the PrEP trial results came out. And then in mid-2012, around the same time as the FDA approval, the interim guidance for heterosexual adults was published. And last, in 2013, we published the interim guidance for injection drug users. Next slide. So now I just want to talk a little bit about the process we use for the comprehensive guidelines development. Next slide. First of all, we set up specific groups of people to have conversations with about how PrEP would be used, what they wanted from PrEP guidelines for their particular area of specialty. So some of those groups were content specific. They were related to clinicians versus counseling staff. Some of them were population specific, so MSM versus heterosexual women. Each of these groups had a diverse membership in which there were academics, there were CBOs. I'll go through this in a second. We had those early conversations in place by the time we developed the interim guidance. Then when the MSM, when the PrEP trial results came out, we decided that we would go ahead and have an external consultation where we brought in people to say, here's what we're thinking right now for MSM. Does this make sense to you? That was our guideline consultation meeting. We also had a process where when we got through all of the populations and got a really comprehensive guideline after all the trial results were in, we have a process of peer review where we send a draft of the guidance to clinicians who would use it and say, tell us what's working and what's not working for you. And then we had a public comment period where we put a draft of the recommendations for the guidelines up. We had webinars, and we allowed the public clinicians, users, advocates, health departments, whomever, to comment about what we were thinking of putting in the document. At that point, we took all that input and we wrote a draft document, and it got reviewed by multiple federal agencies. So it gets reviewed at multiple levels at CDC. The Food and Drug Administration looks at it to see that it's consistent with their statements about the use of Truvada for PrEP. The National Institutes of Health staff looked at it. Our agency called HRSA that deals with clinical care for disadvantaged populations also had a look at it. They are most experienced with HIV/AIDS treatment, but they had a lot of helpful input. And then the agency, all of those agencies report to kind of a massive office called Health and Human Services, and they had to review it as well. When everyone was happy with what was in the guidelines at the federal level, then the guidelines were published. When we get to updates for guidelines, we will do a very a shortened version of this pathway. Next slide. So these were the external input groups that we organized for the PrEP guidelines in 2014. And you can see that the discussion groups that went on over a series of weeks involved several important populations and concerns that we wanted to incorporate in the guidelines. In addition, we had what we called expert panels, which were groups that were focused on a very technical issue as opposed to the broader guidelines. And then for some areas where we didn't feel that there was enough input from these other sources, we had topic-specific calls. And the time to protection was one of those where we convened a special call that included the researchers who were doing that work, the Food and Drug Administration, Gilead Sciences, and CDC to review the evidence that was available at the time and develop a consensus statement about time to protection. Next slide. Within the guidelines, the core of the guidelines is what are the recommendations that you're going to make. And so I want to talk a little bit about how we get to specific recommendations. Next slide. So you will have heard WHO mention the GRADE process. GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation. And this was an international consortium of people who are interested in effective guidelines who came up with this system. The basics of the approach are a systematic review of the evidence with or without formal meta-analysis. And then you use that review to develop evidence profiles that describe the quality of the studies and the certainty of the evidence. So in the systematic reviews, quality is assessed for confidence that the point estimate is correct, but in guidelines, quality is assessed for confidence that the estimate supports a specific recommendation. Next slide. So this is, they start with what is the study design. RCTs are assumed to be of very high quality, so they generally get a score of 4. Observational studies, which is high quality evidence. Observational studies start with a lower quality score. This is an example of a summary evidence table from the PrEP guidelines in which you take each study, you describe the participants in the active and control arm, you describe the limitations briefly, and then you give it a quality rating. There are then supplementary tables that go through different outcomes in a similar kind of format. Next slide.
And Dawn, I'm so sorry to interrupt. As you get to the next slide, I'm very conscious of time, and I realize you still have a number to go. We will be posting these, after the call. So don't stop. But I'd love to move more quickly. That'd be great, and get to the meat, and then we can get to questions more quickly. Thanks.
Then for each of the scores, you can either bump it up or down, depending on certain factors that you find with your review of the evidence. So I'll skip that, and you can go back and look at that. Next slide. This is another evidence table. This is looking at the main outcomes of effectiveness in the PrEP guidelines. Next slide. Now, there's also a process for what to do when you have inconsistent findings, and this is relevant to the issue about time to protection. And the basic guidelines is to look for an explanation of the inconsistency and try to evaluate and, if possible, test out different explanations. So were there different subgroups of patients? Were the interventions the same? Was the outcome defined the same? And were the conduct of the studies of similar quality? This is the place where we are currently in terms of looking at the different time to protection studies. At the time of the PrEP guidelines, the studies were fairly consistent. We now have a new study which is not consistent, and we need to explain that inconsistency before we decide to change the guidelines. Next slide. Each recommendation then is given a rating for both the quality of the evidence that supports it and the strength of the recommendation. Next slide. So in the PrEP guidelines, for example, recommendation for MSM use is high quality of evidence and a strong recommendation. Whereas the recommendation with regard to adolescents, for whom we don't yet have enough data, is based on expert opinion, and it is a modest recommendation. Next. Next slide. So in this case, we wrote the guidelines specifically with the use by clinicians in mind. So we made it shorter. It's not a 300-page document. We specified the audience and the populations to which it applied. We tried to make the recommendations clear and measurable, and we tried to make different sections of the guidelines easily identifiable so that if someone was interested in PrEP and pregnancy, they could go directly to that section. We also worked specifically on structuring the format and the vocabulary of the guidelines so that they could be implemented in electronic clinical record systems here in the U.S., which are often used to support clinician use of a new guideline. Next slide. So here's what it took us. So the initial guideline, we wrote a plan for the development of the guideline in 2010. We had our groups and panels over a 4-year period as the different evidence was coming in. We wrote the interim guidance documents. We did the evidence summary as we were going along, and then in 2012 and 13 we actually did most of the writing. We sent it out for peer review and public comment in early 2013. It went through its final multi-stage review process between late 2013 and early 2014, and then was published in mid-2014. The guidelines call for a major update whenever the evolving evidence indicates changes in graded recommendations. Changes in things that support those recommendations can be handled in a much more quick process, and those we tend to refer to as minor updates. We have not yet issued an update to the 2014 guidelines. Next slide. That's it.
Great. Dawn, thank you so much. Apologies for pushing you to the end more quickly, but really appreciate it and grateful for you to do that. I realize it's now about 10 o'clock Eastern Time and the top of the hour. And in fact, I know there are some people probably just joining. As people will know, this call was originally scheduled to start now. And because of some various scheduling issues, we had to move it an hour earlier. Apologies for those who are just joining now who didn't get that update. But those slides that were presented by Rachel and Dawn will be uploaded along with the recording of their presentations. And they've gone through the enormous processes involved in translating the clinical trial results into guidelines, and you heard a range of different audiences for both WHO and CDC. There are a whole bunch of questions that have come in both before the call even started, during registration, as well as via email and on the chat function. I know that many people, and as people know, this was the second in a series. The first looked at much of the pharmacologic data, not from clinical trials, that was used by both WHO and CDC to consider issues related to time to protection. And Dawn, let me just start. You described the way in which the process unfolds in the review of the clinical trial data and the very strong evidence there. Obviously, much about the conversation related to time to protection is none of that comes actually, as I understand it, from the clinical trials themselves. It's subsequent analyses and modeling of various types. And I wonder if you could, first of all, I know you just said that the initial guidelines have not yet been updated at all. As we heard on the webinar a few weeks ago, that data continues to accrue, and WHO's recommendations, which came much later than CDC's, do have a different interpretation and endpoint. And I wonder if you could just give a perspective from the CDC or from you personally as someone involved in this in terms of the review of the additional data and whether and if CDC is reviewing that, might it make changes, and how might we define or describe and translate these slightly, these different interpretations between the agencies, and just help people navigate through that. Dawn, I hope we didn't lose you.
Hi.
Okay.
I forgot to mute. I can't speak for WHO, obviously, but we are certainly aware of the new data, and it is being considered at CDC. But again, we have a process that has to go through, and I think I tried to address this during the inconsistency discussion. I think we need to understand why different studies are getting different results before we can change our estimation of time to protection. And the reason for that is that from our point of view, this is a safety issue. So if we tell one group of people, after you take X number of days of drug, you're as protected as you're going to be, and we're wrong, then we're exposing people to risk by that information. So it's some things it's just a matter of we didn't have some data, we got new data, now we can make a recommendation. But in this case where we have inconsistent results, it's going to take a bit of time to discuss with virologists, with clinicians, with experts, with the FDA, whether that single study is strong enough to merit changing the recommendation, whether we should wait for an additional study to confirm that finding, et cetera. So we're kind of in the middle. Now, once that process is complete and we know what we want to say, if we feel that it's safe to change the recommendation, then we would issue an update with the changed recommendation. WHO will have to explain how they navigated that territory.
Great. No, and I was just going to turn to Rachel and Giannis. I don't know if you're still on, but either one of you want to just give a perspective from WHO.
Hello, this is Giannis. Can you hear me?
Yes. Oh, that's so much louder and clearer. Please.
Well, it's the Greek in me. Just further to this specific discussion on the time to protection. After the publication of the WHO recommendation on PrEP in the early release guideline, which was released in September of 2015, we acted on the additional evidence that we saw, and this is namely the pharmacological work by Angela Kashuba's lab at UNC in the U.S., which looked at PrEP drug levels in 47 healthy women. This study was presented in the previous webinar, as most of you know, by Mackenzie Cottrell. And in that study, they looked at levels in both tissue compartments, lower female genital tract and colorectal tissue. The study suggested that time to protection in women happens before 20 days, which was what we had written in the 2015 WHO guidelines, and included this in our implementation considerations text. So again, it went into the guidelines, but it was an implementation consideration, and it was not a grade-based recommendation. The actual grade-based recommendation was that PrEP should be offered to any person at substantial risk. So for the 2016 ARV consolidated guidelines, again published in June of 2016, we actually moved to change that text. So within those implementation considerations, to actually make that shift from 20 to 7 days for both men and women. In terms of process, we actually convened our technical experts, our clinical researchers, and our key pharmacological focal points for this work before we made that change. It was included in the ARV consolidated guidelines. It went through the GRC, the Guidelines Review Committee, and that was accepted. And so, yes, I mean, in essence, we moved from the 20 to 7 days based on, this one study, but which, involved in-depth discussions and debates with these partners before we made that decision.
Great, thanks, Yannis. And I wonder too, and maybe
just to let you also know, I'm sorry, we also had like a technical consultation on PrEP drugs in March of 2016, where we actually discussed this particular element as well, and where Angela Kashuba presented. So it was very much a work in progress. But I think Dawn spoke to it before that one also has to. You can't necessarily have this perfect plan where you say how often you will update guidelines. But this wasn't. It was an important consideration in terms of the text, and it was based on that paper published in JID. And so that's where we rest as an agency on making that implementation consideration. So I hope I'm clear on that.
No, thank you both. I wonder also, and again, both organizations, both agencies, there are issues, and you both raised it in the process conversations, but there are issues about both provider preferences or provider experiences as well as programmatic feasibility, and whether you're talking about countries responding to WHO or municipalities or states responding to the CDC and then individual clinicians. I wonder if both of you could address this issue of how do provider preferences and the feasibility programmatically fit in, and generally, but particularly with respect to time to protection. And also a question came in, how is this being monitored in terms of, and is there anything in place to monitor around this to accrue more data to understand this with any greater certainty? So I'm happy for either one of you to start, but wonder if either of you could start.
So this is Yannis. So we are very much cognizant of the, obviously, because we made the shift from 20 to 7 days, and we're convening an informal working group right now to address the M&E, the monitoring and evaluation component for programs and PrEP services globally. So this is part of it, of course. That's all I have to say on that. Dawn spoke to the kind of the issue from the CDC perspective on how this is a safety issue in making the move from 20 to 7 days for the CDC. For us, it really was an implementation consideration. It's on behalf of WHO. I don't think we sit here to consider that we would be placing women at risk from making that shift from 20 to 7 days. If anything, internally we felt that's actually more of a conservative estimate to protection. There are levels of protection, after 2 doses, but we moved it to 7 days on that. And again, this is an area that we are actively working with, ensuring that we generate more data, particularly with countries that we work closely with, such as South Africa and Kenya on this, as they are early implementers of PrEP within sub-Saharan Africa.
Great, thanks, Giannis. And Dawn, I don't know if you have thoughts on that.
Well, there's 2 things. First of all, I would not like anyone to misunderstand me in terms of it being a safety issue. I think that's a general principle. If in fact 7 days or 5 days is the right answer, then that's also the safe answer. I think what we have right now is uncertainty around how to incorporate this one new study into the existing database in a way that we are sure that we're sure of whatever statement we make, or we have high certainty. And I think it's entirely common in science to have different groups of people look at the same data and not necessarily evaluated in precisely the same way. So this is not unexpected, and nothing that I said should be taken to mean that I think WHO is doing something that is unsafe for people. In terms of monitoring it, I think you can't really approach this from monitoring. This really has to be a research thing. Because, we don't detect HIV infection quickly enough in program to actually monitor this. So, that would require you saying, this person got infected, 14 days after they started PrEP because they didn't use condoms, and this person didn't. That level of precision really isn't possible in implementation mode. So we can certainly monitor people's use of PrEP, their uptake of PrEP, whether they have toxicities, whether they seroconvert, and how that's related to their adherence. All of those things can be monitored in implementation mode, but I'm not sure that time to protection can be. I think that really has to be a research protocol. And it has to be modeling protocol, because ethically you couldn't randomize people to different exposures to HIV at different points in their PrEP initiation. So when I say research, I'm not talking about putting anybody at risk. I'm talking about more of the laboratory-based research that's been done. I think one of the strongest features of the data for MSM is that they have been able to use the laboratory data and link it to the clinical trial data in a believable manner, so that it can then be sort of validated. Their modeling work can actually be validated in the experience of a clinical trial where you have measures of drug levels and you have measures of incidence. I think we've been more challenged doing that with the studies with heterosexual women.
Great. Thanks so much for that, Dawn. Just one quick thing for everyone's knowledge in terms of the research agenda. The earlier webinar on this topic included Craig Hendricks, Mackenzie Cottrell from Angela Kashuba's lab, and Pete Anderson, who reviewed the data that they've accrued in different studies. Either Dawn or Giannis or anyone else are aware of, and they posited that it could be anywhere from 1 day to 21 days to protection through different analyses. but I don't recall, and maybe one of you might know, is there a specific additional research design that you're aware of, either from any of those three or others in the field, who might be trying to design something to help answer this question and provide additional data? And I don't know, Dawn or Giannis, if you're aware of any.
I personally am not, but I think if we asked Angela and Pete and others, they would know.
Okay, and it may be
So
go ahead, Giannis.
Indeed, this is actually a sort of an important discussion point. We had a call with Angela 2 weeks ago, and just discussing this a little more actively to see, what additional data could be generated to support that change. I mean, right now, again, as I said, in the WHO context of recommendations, it's not an actual recommendation. But we would be happy, and so this is sort of the area that we're working on. But we have a PK technical group, and Angela and Peter are part of that. So.
Great, thanks for that. And Dawn, you had said something important, I think, about the ability to link the laboratory-based modeling with the clinical trial data, and obviously more data accrued in the trials amongst gay men and other men who have sex with men. But a question did come in, and I wonder if you know, having been involved in some of these trials, in the clinical efficacy trials, did we see any number of women getting infected within a 20-day window, or were there numbers at all large enough to know? I mean, was there anything from that data that might suggest or imply perhaps a differential level of time to protection? Do you know?
Certainly the trial I'm associated with, we did not see that. So people who came back at month 1 and were infected always had virus detected at their baseline specimen. They were inadvertently started when they were an acute infection. So you'd have to find that subset of people who were not acutely infected but were infected when they came in for their 1-month visit. And then within that, you'd have to try to figure out when in that 30-day period they got infected. So that's what I'm saying. Measuring time to protection in that way is probably not possible.
Okay, thanks for that. There's another question. Dawn, both of you described the processes involved at great detail. And I know, Dawn, in your slide you talked about the various inputs and consultations, and not just from researchers and clinicians, but also from CBOs and NGOs. And I wonder, Giannis, I know in the WHO process there's a lot of conversation in any guideline development about values and preferences of potential users of any intervention. And I wonder if you, and I don't think Rachel touched on this, but can you describe, and again, particularly related to women's health groups in Africa, where this issue is so emotive and so important, can you describe at all the way in which values and preferences were understood and measured and evaluated, and how, if at all, women's health groups were consulted as part of this process?
So I actually came on board, after the GDG meeting, and where the values and preferences work was actually more than a 6-month process prior to the actual GDG meeting. And afterwards, as Rachel mentioned, over, I think 200 people reviewed the actual guidelines, including groups, civil society groups, women's groups. So they provided feedback to us on the guidelines, and that was inputted in there. And so that reflects, kind of that broader consultation from civil society groups, and which included womenens groups.
Great,
so
thanks.
That's all I can say for that. Pardon. I mean, I wasn't part of that process that led to the actual 2015 recommendation. I've been working more on the implementation toolkit.
No, thanks very much. I know, and just so people know, Rachel, one of the reasons rescheduling, Rachel had a plane to catch, so I think she might be off already. I'm going to open up, just invite people to take additional questions and comments just a moment, but I did want to just say one thing, or ask one question that came in the chat feature in particular, and that was, Dawn, you have a really impressive slide that showed how much faster the CDC and the broader community has been, certainly in the U.S., around the PrEP guidelines compared to other interventions. And a question early on, as Rachel was describing the WHO process, someone commented and said the process seemed quite long. We're sitting here in 2017, a number of years post-efficacy result. And a question of, based on this experience, is there a sense of how future guidelines, and I think people here might be thinking particularly of the next wave of PrEP, whether that is oral FTAF, whether that is injectable cabotegravir, whether it's the dapivirine ring, is there a sense of how perhaps to further condense the time frame is somewhat similar to what Dawn was presenting on the U.S. side? So just a question there is there any way to go faster?
Yeah, I think so. I mean, you raised a couple of different agents which will be different. So, for example, if we find that TAF works, that would be handled as an update to the PrEP guideline, oral PrEP guidelines. That would not be handled as a new guideline for TAF. Cabotegravir and rings are kind of different categories as well. So cabotegravir could be handled as a PrEP guideline update. Would probably not be because of the complexity of how it's administered. The ring, however, I think would almost by definition be shorter because it's only dealing with one population. A major part of the length of our development was that the data for different populations kept coming out. We could have written the guidelines for MSM and then updated it for other populations, but every time that we got close to having a final guideline, another population would show efficacy and we would have to incorporate those things into the guidelines. And so that accounted a lot for the time that it took to actually get to full guidelines. So I think for the ring, since it would be for heterosexual women, it would be over and once the trials showed efficacy. The other thing I think is that we started early when we thought it might work, and we did as much of the front loading as we could. Now you can't do it all because you have to see the final safety and other findings. But again, given the experience that we now have with oral PrEP, I think the next one will be faster.
Great, thanks. And Yannis, can we go faster at WHO?
We can try, and that's the plan. I must say that the actual process for the 2015 recommendation from the GGG meeting to actually the early release document that happened was actually quite fast. To actually get a guidelines written, approved, and through the Guidelines Review Committee and published, that was actually done in from June to September. That's 2015. That was a pretty short amount of time, in my viewpoint. What I will say is, and I agree with Dawn. I mean, I think we also have a better understanding of the safety issues and implementation issues. As we are rolling out oral PrEP containing TDF. So I think there's a system in place now, of course, and hopefully for the next products that are coming into the pipeline, if shown to be efficacious in RCTs, we hope we can move through that faster. That said, I think there's we also want to ensure that in-house, when we actually decide when we would trigger the guidelines process, that we actually make sure we have and partners have generated the data that is needed to ensure that we have a recommendation at the end of the day. So, it can be unfortunate if you actually trigger the guidelines process and you already know that you would not be making a recommendation because either the data is too weak or it's not, or the product itself wouldn't meet the values and preferences of the end users. So we may end up having a product that worked really well, in one or two RCTs, but ultimately when we are doing our preparatory work, we're starting to see that ultimately people that can benefit from these interventions really would not want to take it. So all these things need to be taken into account, but I agree with Don. I think we can move through this faster for next phase products.
Great, thanks, Giannis.
Mitchell?
Yeah, go ahead. Go ahead, Don.
Two things. Number one is, first of all, I was discussing the time to the full guidelines. Remember that we did interim guidelines within months of each trial results.
No, absolutely.
The second thing I would say is that for the rings in particular, there is a built-in delay for the U.S. in that they would have to go through FDA approval, and then they would have to be manufactured and marketed because they are right now just research entities. And that process in and of itself allows for time for development of guidelines.
That's a great point, Don, and I think you raised it earlier.
Go ahead, Giannis. Just a question for people on the call to also recognize the challenge when you're making global guidance, right? And you're trying to serve all regions of the world. Particularly, as Rachel mentioned, our focus is low middle income countries that have less resources. It becomes a challenge in ensuring that what you are recommending can be implemented ultimately. So that's why at times things do take longer, and we have to have global and regional input from all corners of the world into the actual guidelines process and the draft guidelines that are written before they're GRC submitted. So that's what we struggle with. But it's part of the process, and that's our role.
No, I appreciate that. And I do just want to, I think, Don, your point really importantly, I think for PrEP advocates, broadly speaking, there are some fundamental differences between an entirely new product, drug entity, the vaginal ring or cabotegravir, which is right now not approved for anything, treatment or prevention, as opposed to a product like TDF-FTC or FTAP, which are previously approved for treatment. So it does change that scenario. So I think it's a great point. A number of additional questions came in. I want to just quickly get to them, and I know it's now half past the hour, and many of you have been on for 90 minutes, although some of you only joined at the top of this hour, so it's all very fresh. One quick question came in, just to follow up to you, Giannis, a really simple one. In terms of the engagement with civil society and advocacy groups, a question just very specifically, did any of those groups raise questions about time to protection in women, comparing it to the CDC in the U.S.? And that was just a simple question. Did any objections or concerns get raised?
My personal answer, I don't know, so that's why I'm not going to answer that question. But I can definitely look back into what were provided from all those comments. If there was any red flags raised or concerns. But I'm happy to do that. But I just can't answer because I don't know.
No, I think that's really, really important. And again,
Rachel's not here to answer. Apologies, but it's something we definitely will go back and see to do our due diligence and check to answer to the question.
I think that's a really important piece, just for clarity's sake. I do, again, I realize, and if people are staying on there, you're not hanging up, so I'll keep asking a couple of questions that came in. Again, the issue, and this is more broadly about the plan going forward for recommendations. Someone asked the question that part of the slowdown was this confusion or lack of specificity about efficacy and effectiveness, and that people grappled with the number. And a question, I guess, both with oral PrEP in the short term, but also other interventions in the longer term, is there a way to better manage that and how we communicate around that?
Actually, that had nothing to do with the time to our guidelines. We worked on the guidelines with the initial trial result data before we had all of the extensive adherence data available to us.
Great, appreciate that. And Giannis, is that similar from your perspective?
I think so. I also recognize that the initial recommendation on PrEP by WHO in 2012 was, to kind of provide support for demonstration projects. And then we actually moved to making a recommendation specifically for MSM in the KP guidelines in 2014. And then waited and recognized it's the efficacy out of RCTs that was the basis for the 2014 recommendation. But the 2015 recommendation was sort of a mix of demonstrating efficacy in RCTs across a variety of populations, and then the emerging implementation projects and demonstration projects showing effectiveness and high effectiveness of PrEP, particularly in those who adhere. So that was sort of the broader recommendation, and the stronger statement for any person at substantial risk was sort of a mix of the RCT data, of course, and observational studies that were included in the systematic review. So yeah.
Great, thanks for that.
I'm sorry. No, that's fine. I'm done.
Okay, so let me, a question, a key question that many people have asked for weeks and months, and it came up on the call with the pharmacologists, and I don't know if any of them are on, but I'd love to have both the representatives of CDC and WHO answer it. One of the things, and again, for those who missed that first call, I think that recording is a really important one to hear the data behind recommendations, but one of the things that a number of presenters talked about is that there's the modeling research occurs in two places, and let me see if I get this right. Dawn and Giannis can correct me. There's both looking at the time to reach what we think are protective drug levels, and there's data about time to reach specific drug concentrations in particular tissues, and those are two different things. As again, I'm just trying to see if I'm getting this right and help us all. So and someone just sent a great question saying, it seems as if the WHO recommendation or guidance information, it's not a full recommendation, is guided by estimates related to that time to protection, whereas CDC, looking at some of the same data, is looking very much at the drug levels in particular tissue. Now, perhaps a number of us are getting that wrong, but if one or both of you could say, is that a fair articulation, and if not, what would be a more accurate way to understand it, and what would be, and I think this is one of the take-home bottom line questions from a number of advocates, just one of them just send this from Africa, of what do we say after today? So I don't know if either one of you can help us understand that.
I think it's more complicated than what you just said.
Okay.
The thing is that there are plasma levels, there are blood levels of drug, and those are concentrations. There are tissue levels of drugs, and all of those can be studied in the laboratory. Unfortunately, in clinical trials, you don't normally have tissue levels of drug. So trying to figure out which of those three kinds of drug levels, vaginal, rectal, and blood levels, is most associated with protection or time to protection means that you have to somehow get from the laboratory measure to the clinical trial data in which you can talk about effectiveness over time. And that makes it very complicated. There's no simple answer. And I think particularly that because we don't have tissue levels in trial participants, it's hard to say that this tissue level that I found is associated with this level of protection. You can do it with modeling, but then you're modeling.
Yep.
So just further to that point, it's like, we as WHO, we were confident in the study by the Kashuba group, And obviously, hence, we made that move. I think what's also important for people to appreciate is there is a difference between time to steady state and time to protection. So you can reach levels of, to protective levels of drug in the relevant tissue before you're actually reaching those steady state levels of drug. And so I think that is an important distinction. The other thing that is also important to sort of relate to people who are not necessarily involved in clinical research and PK research is that and a message that needs to ensure that it's going to PrEP providers, potential PrEP users, and the advocacy community is not stating things such as time to maximum protection, because there's no such thing in medicine, particularly in the area of PrEP, as we know, and so this speaks to when you would have individuals where they are adhering to their to their PrEP medicines and they will still get HIV infected. Obviously, we never say anything in terms of 100% effectiveness. We would never do that. We recognize there's a level of uncertainty in medicine and a level of uncertainty in the data that is generated from these studies. And Dawn spoke to sort of the challenge in actually getting tissue samples from the RCTs. So you then have to do the other type of work that was done in the JID paper by Angela's group. So just to say that, I think key points, nothing is absolute in medicine in terms of the evidence that is generated and what we either put in WHO recommendations or text in implementation considerations, as is this language on time to protection. That is, that really is based on assessing the data that's in front of us, and where we landed was, to say that this was, this study in 47 women, in addition to the previous data that was actually considered, by the team here and the technical group, was actually, was of quality and actually landed towards the truth. But that's, I think that's sort of my perspective on that.
Great.
Yeah.
Go ahead, Don.
Just two additional points. One is, actually, we don't know the relative contribution of tissue levels versus plasma levels to protection. So it's feasible that some portion of the effectiveness occurs at the mucosal level, and that when virus escapes that level, it can be blocked by circulating drug in the lymph nodes. So again, it gets very complicated. We're acting as though if I have enough here, I'm done, and we don't actually know that. The last thing in terms of what to sell patients, I think this gets to the shared decision-making model that we use in the U.S. And what I would say to a female patient of mine based on this is, look, we're putting you on PrEP because you're at high risk for acquiring HIV infection. There's a difference of opinion in the data about how long it takes to build up enough drug to protect you adequately. And to err on the safe side, I would say this, but some people would say this. And then the patient leaves with the information that they need to take whatever actions they need to take, but then emphasize to them that the most important factor is taking the drug regularly.
It's a really great point, John. Thank you for that.
Absolutely. Okay. Just further to Don's point, I think also if you're looking at the data, if you're talking to individuals and groups such as Angela's group, we recognize that TDF is not as forgiving in the female genital tract as it is in the rectal tract. So that's that underscores again the ensuring that that adherence is critical to somebody who desires to be on PrEP. I mean, not only for MSM, for example, but particularly in women, because missed doses are not as forgiving. And so, yeah, that's just kind of further to Dawn's point on that.
Great. Well, whether you've been on for whatever 90 or 100 minutes or 40 minutes, or whether you've been looking and talking about PrEP for the last 14 years, I think everybody knows nothing about PrEP has ever been simple, and you all have just helped confirm that. I realize we are have really gone quite over time, but happily so. I do want to. There are other questions that have come in. I do want to wrap up in just a minute, but I do want to just see if anyone does want to raise a question. I realize this is a very emotive issue, so I would ask that you can unmute with *7. I would say remute with *6 to keep the line clear so we can post the recording. And I would ask that you introduce yourself and keep it relatively brief so we can take a few. So if anyone has a comment, I'd welcome that with *7. I will pause for another few seconds in case you're struggling with the mute function. All right. So this is obviously has never been a discussion that would end in a single webinar. But I do think, and Dawn, some of your last comments and Yannis is about how we go forward, what we're saying, the idea of the full information and shared decision making in the midst of uncertainty. And for those of you who've been on previous AVAC webinars, one very recently about hormonal contraception and HIV risk, we operate in I'm sorry, I just got a note from someone who tried to unmute. Try again, *7.
Hi, this is Jim Pickett with IRMA. Am I unmuted?
Hey, you are now unmuted.
So I just wanted to make a quick comment and just and bring up a concern. I think these differential recommendations are very problematic for how we message and how we talk to people. If I was someone coming from the outside, it would look to me like we are valuing women's safety and health more in the United States than we are in other countries. I'm talking as if I'm just arriving to this conversation. I'm concerned that it seems that there has been a weighing of implementation and ease of implementation in the WHO recs compared to the CDC recs. I think there is enough different interpretations of the data to err on the side of being conservative. So I think this behooves many more conversations. I wish we had gotten to this conversation much sooner in this call. And certainly advocates and researchers and normative bodies, et cetera, need to come together and talk about how we talk about this in a global world where we're all digitally connected and can see all these different messages. Thanks for letting me get my piece in.
Great. Thanks, Jim. Before I close, Yannis or Dawn, any comment or reply?
No, thank you for the opportunity.
No, it's thank you as well to AVAC, and Jim's point is well noted and well heard, and I think there's underscoring the challenge. From our side, we develop guidelines that take the public health approach, and at times by whether it's certain individuals or certain groups, maybe perceived or understood or interpreted as not being as patient or person oriented, because it's taking a public health approach rather than an individual medical approach. And again, not to speak to sort of what the CDC does, but when concerns around are we potentially compromising the safety of people that can benefit from PrEP, on the ground. And if there is a discrepancy, let's say, between what we are trying to say in resource-rich settings versus resource-limited settings, these types of conversations and concerns are well noted on our side, and and we take them very seriously. So that is my viewpoint, and thank you again, Jim, for sharing your concerns.
Great, and thanks, Giannis and Dawn and both the teams on both the organization side to get us there. And as Jim said, this conversation is not fully resolved and likely won't be for a very long time. I'd like to think that everybody on the call, no matter where you are and no matter what you do within the PrEP world of delivery or advocacy or are a PrEP user or a PrEP provider, that we recognize that the most important thing is that we operate with the greatest of care and safety, but that we also act and don't not do PrEP. And there are many people who would love to see this, and again thinking of Jim's analogy of coming in from the outside, there are some who many know would love to use this as a reason just to stop and not do PrEP. It's too complicated, it's too uncertain. And I know that I'm confident that no one on this call, and hundreds of you, would want that. And if you are one of those people, I don't know why you're on this call. We, I think, hopefully are all together and trying to figure out how to implement oral PrEP and give it and offer it to people who are at risk, and operationally and programmatically be sure we're doing that with care and safety. That's an easy thing to say, as you heard from both CDC and WHO, still with a great deal of uncertainty, and the conversation must continue. I also just want to say I'm struck because, of course, this is not the first time guidelines come with slightly different interpretations of evidence, and in fact, in the HIV space, I think for many of us, the one that's most notable was recommendations from the U.S. many years ago, talking about the offer of treatment upon diagnosis. And many countries in Europe and in Africa, and certainly WHO, waited a very long time to move to a point where we can say treatment should be offered upon diagnosis, and that the take-up of treatment, not to be given to someone, but the offer of treatment to someone to then make that decision. And I'd like to think that is the same with PrEP, but we all have to work with the guidelines that are there and push them to be consistent when they can be consistent, and operationalize them when we need to. And that really comes down to the country level work. And I know many of you on the line are in countries where you're actually part of programs trying to design and implement PrEP programs, and we've got to figure out how to do this so that a person, and we can talk about 1 day to protection or 7 days or 20. I think Dawn's point of making sure people know that PrEP works only when you take it consistently, and that is not just 1 day or 7 days or 20 days, but for that period of risk. And again, I realize that doesn't address the time to protection and resolve that, but we need to be sure it's in the context of how are we doing sustainable programs that can show if PrEP can indeed have impact and reduce new infections, which I know everybody on this call wants to do. I undoubtedly can predict that there will need to be a third in this series, and we will look to how we organize that. I think a number of questions about inputs from, we've now heard from pharmacologists and as people leading the generation of that information. You've heard now from the leading U.S. agency and the leading global agency working on guidelines. We clearly still need to hear from those guideline development processes at the country level, in Africa particularly, where PrEP is now being rolled out in increasing size and scale. And most importantly, need to hear from both users, user groups, advocacy groups, and civil society to understand how we take this forward, because like anything we do in this field, it is not just about pharmacology, it is not just about guidance, it is not just about health provision, it's about hearing from those individuals for whom we're really trying to make this work. So we will look at how we organize that for part 3. Apologies both for the change in time, and especially apologies for those of you who only joined 50 minutes ago, but others of you have stayed with us for an hour and 50 minutes, and I'm enormously grateful. We will be posting the slides and a recording and follow-up information, and hope to keep that conversation going. So thank you everyone for your patience and perseverance and very long adherence over the call, and stay tuned for what comes next.